Hello, this is Dr. Alan Schwartz welcoming you to Essentials of Laryngospasm Concepts Online. I present this disclaimer to you to show you that there are other opinions and other things that you can read and learn from other people, and that this is not the wherewithal for the definitive advice on laryngospasm. And I encourage you to seek other textbooks, nursing textbooks, medical textbooks, dental textbooks concerning laryngospasm and how it occurs and its treatment. Our learning objectives are we're going to first introduce you to what laryngospasm is. We're going to cover some very basic anatomy of the pertinent structures that are surrounding the causes of laryngospasm, the definition of what laryngospasm is, who are susceptible patients, the treatment of laryngospasm, the prevention of laryngospasm, and then we'll summarize everything and reach some conclusions. We're going to be looking at the mechanisms that protect the airway. And a triggering event can occur to prevent fluids or solids going down into our trachea. And we're going to discuss those steps and attempt to prevent that from happening, because when it happens, it can be very sudden and it can be very stressful for both the patient and the people that are providing sedation to the patient. Let's talk about our introduction. You'll see that this is a normal open adult airway with the vocal cords abducted. You can see that you could look down into the depths and notice that there is tracheal tissue there. You can see some of the cartilage rings. So it's very, very close to the vocal cords. And the vocal cords are really the only protection from anything going down into the trachea. Then we'll see a normal open pediatric airway. Look at how thick the epiglottis is, the tissue on the superior portion of this picture, and notice how small the glottic opening is. Look at how small the vocal cords are in relation to the adult. So we've got a lot less real estate, if you will, or square foot area, or whatever you want to call it, to have the spasm and to close. We don't have a lot of room, especially in the pediatric patient. So the pediatric patient does have a very small opening, and in fact, when we're putting in an endotracheal tube, for an adult we use a tube that has a cuff on it, an endotracheal tube with a cuff. For the pediatric patient, we use uncuffed tubes, and if you will, they look kind of like a McDonald's straw. Of course, they're endotracheal tubes, but up until about age 8, that vocal cord glottic opening is very small, and we don't want to cause any bruising or swelling of those vocal cords to cause them to swell closed. Then we see a picture of what laryngospasm looks like. The vocal cords in this picture that the arrow is pointing to are spasmed shut. There's no entry or exit of any gases. We don't want any fluids to enter, but it is naturally spasmed shut by a pretty powerful stimulus, and it's a powerful spasm that's going to close that glottis. Know that laryngospasm is rare, and it is preventable and quickly treatable. And treatment can occur along a spectrum, meaning that we can go to some moderately non-invasive treatments to break the spasm, and to invasive treatments like applying or administering a powerful muscle relaxant to relax the vocal cords. And we're going to talk about that during this lecture. The treatments can occur by both either one person, so a solo person, but it's better to have trained individuals to be able to help with a patient experiencing laryngospasm. There's some armamentarium you're going to have to gather for the patient, and it's best to have trained individuals help you with that. As I said earlier, laryngospasm is almost always preventable. Let's talk about some basic anatomy of the mouth and the throat. First, we should see the three pharynges. There's the nasopharynx that extends, it's from the base of the skull, but you can see it's right along the soft palate, extending to about the area of the first cervical disc, which is C1. Then we have the oropharynx that extends from the inferior portion of the soft palate, you can see it right at the tip there, to the tip of the epiglottis. And we're looking at this on a side view. It's a sagittal cut, and the epiglottis is to your left, just to the right of the base of the tongue. That area that is between the tongue and the epiglottis is called the vallecula, and that's at about area cervical disc C2 to C3. And then finally there's the third pharynx anatomically, and that's called the laryngopharynx, and that goes from the tip of the epiglottis down into the trachea. So that extends from about discs C3 to C6. Let's look at some pertinent basic anatomy for the larynx. There is the vallecula again that extends from the base of the tongue. It's a space that is between that base of the tongue and the epiglottis. And if you're using a Macintosh blade to intubate a patient, or if you're using one of the lighted electronic screen video laryngoscopes like a McGrath or a CMAC, that is the area where we slide the blade, lift the tongue up, which in turn lifts up the epiglottis. The epiglottis is a cartilaginous mucosal substance that's fairly rigid but does bend. It is pliable, and theoretically it does not cover and protect and close the glottis the way that we would like. And then you'll see there's the lingual tonsil also at the base of the tongue. So the glottis is defined as the entrance to the airway. We'll be using that term quite a bit. That's the area we're going to prevent or have laryngospasm. Let's just look at those cartilage of the larynx again. The important anatomy of that area is the epiglottis. You can see that there without a mucosal cover. There's the hyoid bone that lifts musculature to cause our voice to change. And then there's the thyroid cartilage, in which sits above that, or if you will, superior or anterior, is where the thyroid gland sits. Then there's the arytenoid cartilages, and this is where the vocal cords are going to connect. And finally, there's the cricoid cartilage. That cricoid cartilage is the only continuous tracheal cartilage band, and if we're applying something called cricoid pressure, it's to collapse the epiglottis so that we don't have any reflux and potential aspiration of stomach contents into the glottis and then down into the trachea that can cause quite a bit of harm to the patient, and that, when that happens, is called aspiration. The next shows you a side view of those same anatomical structures. Take a moment to learn those and see where they relate to the glottis. The next is an anatomical picture of the anterior view of the trachea. We see the epiglottis again sticking up again above the hyoid bone. There's the thyroid cartilage. Thyro means shield, and it does look like a shield. That is also the name for the Adam's apple. Then there's the cricothyroid membrane, and then the cricoid cartilage again. That's again that only continuous cartilage. The reason I'm showing you the cricothyroid membrane, as you can see it extends from the cricoid to the thyroid cartilages, is if we had to do an emergency tracheostomy, that is the membrane that we would then palpate and then puncture if we needed to get an emergent airway. Let's look at the powerful skeletal muscles of the glottis. You can see that there are some really powerful muscles that bend the arytenoid cartilages that are right there adjacent to the vocal cords. And there's the vocalis muscle, the vocal ligament are the vocal cords. And so we've got some really powerful muscles that constrict or relax to cause the different tones and to protect the glottis, the different tones of our voice. I want you to see that on the right side of the trachea, as we go into the split of the main stem bronchi, the split is called the carina, but notice that there is a head-on drop from the trachea down to the right main stem bronchus. So most of the aspirate is going to go down straight because of gravity, straight into the right main stem bronchus, although of course we can have materials and particles and liquids and acids enter both of the main stem bronchi. Again, there is where the aspirated substances typically head, and it's down and to the right. Then I want you to see how the thyroid gland, and it is extremely vascular, is so close to the thyroid cartilage and sitting by the cricoid cartilage. We're extremely fortunate that it does not lie over the cricothyroid membrane. So we're able to do an emergency tracheostomy as we talked about before. I want to show you now some anesthesia tools that we use to evaluate the airway, and we do this preoperatively, and we document it on the patient's pre-op notes. These pre-op notes are available on the website sedationconsult.com, and you're welcome to go there to download any forms that we have that I use in my practice. So you're welcome to look those over. The airway evaluation tools that we use are, the first off is called the Mallampati classification. This is where the patient opens their mouth as absolutely wide as they can and sticks their tongue out without saying ah or making any kind of muscle contractions. If you can see the entire uvula, that is called a Mallampati class 1. A Mallampati class 2 is where you can see the base of the uvula but not the tip of the uvula. Notice that in the Mallampati 1, you can see straight down the throat. This is somebody that's going to be probably really easy to intubate. A class 3 Mallampati classification, we only see the base of the uvula when the patients stick their tongue out. And then a class 4 Mallampati patient is one in that you can only see the soft palate. These are only just a general guide. I have intubated patients that have a Mallampati 4 and not had a bit of difficulty with it. So it's good to have these tools so that you know to have people to help you or someone there in case we have some problems obtaining or maintaining the patient's airway for them. Because the airway is one of the most important things absolutely that we have to have for the patient in order for them to exchange gases and to stay alive. One of the other tools we use is thyromental distance. And what you want to do is use your fingers going sideways from the thyroid cartilage along the bottom of the neck underneath the chin, and you calculate how many finger breaths it takes to go from the thyroid cartilage to the mentum, which is the chin. And we chart those as finger breaths. We also have the patient go into a sniffing position. This is the sniffing position in which if you were smelling a really good cherry pie or something on that order, and you'd bring your neck forward into try to sniff and really get a good scent, you have the patient do that and you look at how well they are able to get into that position. We use the angles classification identical to what we learned in dental school, to look at from the top of the head down to just below the nose to the mentum, the chin. So we have an orthognathic patient at the top, where that is a straight line. If you were to go from the top of the head where the eyebrows are, just above that area, down to just below the nose to the chin. A retrognathic patient is the patient in the center, and they're going to have a normal sized adult tongue, but they're not going to have a lot of room to tuck that tongue in, so that can be a real big airway problem. The third patient is a prognathic patient, and this is a patient that is going to have a lot of room to be able to get that tongue in, and is probably going to have a chance of having a really nice airway. The next thing that you'll see is the neck range of motion. So we have the patients go through tilting their chin down to their chest, bringing it up as comfortably without hurting their neck as high as they can, then looking straight back at you and turning their head to the left and then to the right, and then tilting it from side to side. We want to chart a good neck range of motion. That's going to help us be able to make sure that the patient is going to be able to bend, and we're going to be able to control their airway better. Let's go through some definitions. So as we talked about at the beginning introduction to this class, laryngospasm is a protective mechanism to prevent aspiration. Aspiration is when either solids or liquids should be going down into the esophagus, but instead mistakenly or accidentally go down into the trachea, where a lot of bad can happen. It's a really strong reflex. It is a spasm of the larynx and those extremely strong vocal cord and musculature of the vocal cord and glottic areas. So they snap shut just reflexly and will stay shut until a substance or that liquid or solid is removed, and ways that we can remove it artificially in ways of treating the laryngospasm. So what the epiglottis is supposed to do, and we alluded to this in the anatomy lecture, is that it should be the boundary. It should flap over the glottis and prevent anything from going down into the glottis that should not be there, other than air or carbon dioxide, oxygen and air coming in and out. But it should protect us from having solids and liquids go down and even have a chance of getting to the trachea. And the interesting is, something that we learned in school is that pigs' anatomy has the right idea on what an epiglottis is really supposed to do. And they have a protective epiglottis. You'll see that the anatomy, if you look at it, the hard palate and the soft palate are at the bottom of the picture. Then we go to the glottis, and theirs is very movable and pliable, and it's sitting right over the glottis. And then at the top of this picture is the pig's tongue. So it is a much more protective mechanism, the epiglottis, than in the human. One other thing that the pig has is that they have gentle angles for their airway. And we have very sharp right turn angles, and that makes for liquids dropping down and having the chance to go into the trachea. So you'll see that I have that circled in blue, that gentle angles and gradual curves, and that protective epiglottis really prevents substances from getting down into the trachea and instead going down to the esophagus where they're supposed to go. Notice again that humans have sharp curves. I've outlined those in red from the mouth toward their airway and toward their trachea. There's a lot of chance for intersection and things not going the right way. So you see these sharp curves in the closeness of the epiglottis and the trachea, and the esophagus and the trachea. There's just not a lot of room and protection there, especially when we're swallowing or breathing. So the swallowed water should go to the esophagus and instead can end up in the trachea, and that's when we have our problems with laryngospasm. So laryngospasm presents itself with some anatomical and physiological episodes. The first being that there's sudden laryngeal and glottic closure. It just absolutely and strongly snaps shut, like we talked about early in the lecture and we've repeated several times. The glottis closes and it spasms. It's extremely strong spasm. The vocal cords adduct, as we saw in the picture earlier, and just stay closed. If the patient is forcefully coughing and trying to clear it, that's the best thing that we can do to take care of a laryngospasm. And we'll talk about that a little bit later. It's best to have the patient forcefully open up by coughing their glottis. But when we apply sedation and administer sedation to a patient, we blunt those reflexes and the chance for that coughing to occur, at least partially, or it might not even be a strong enough cough to open the adducted vocal cords. When there's closure occurring, there's exaggerated abdominal and diaphragmatic movements because air cannot move in and out, so there's kind of a rocking horse spasm of the patient's abdomen and their diaphragm because of no air movement. There's choking. There can be some vocalization if the vocal cords are open just a tiny bit. Air might be squeaking by, but it's not enough, and it can spasm, like I said, shut so that there's no sound whatsoever, which would be the silence occurring when that happens. You're going to see end-tidal CO2 drop down immediately, and you probably won't even have a signal there because there's no carbon dioxide and oxygen being exchanged. Later, there's a precipitous drop in their oxygen saturation, their saturation pulsatile of oxygen, which can lead to bradycardia and then death unless something is done very quickly to treat this laryngospasm. You'll see in this movie what normal vocal cord movement looks like. Then this movie shows you laryngospasm. So who are the patients that are susceptible to laryngospasm? Any patient can have this occur. Any of us that have drunk a soda pop, maybe swallowed or was talking and had it go down, if you will, the wrong pipe, have experienced laryngospasm. That has happened to any of us. Usually patients, if they're very young, because of the nature of their larynx and the opening of their glottis and the smallness of their vocal cords, can have an experience with laryngospasm. A patient with GERD can have laryngospasm occur. GERD is gastroesophageal reflux disease. A patient with an upper respiratory infection is especially susceptible and has a very ticklish and very spasming, ready to spasm glottis because of the cold that they've got, their upper respiratory infection. And in fact, we're taught in anesthesia school that any pediatric patient that is less than 14 days out from an upper respiratory infection with a non-emergent procedure that has to be done, we cancel the case and we move them to at least 14 days or greater so that the URI has a chance to clear up. Their vocal cords and their glottis are so susceptible to spasm and laryngospasm. An asthmatic patient is susceptible. Somebody with an airway anomaly, it could be from surgery or it could come from a birth defect in their airway. Somebody that's had past head and neck surgery, even if it didn't involve the glottis, can affect the anatomy of the tongue, the neck, the trachea, and make the patient susceptible to laryngospasm. Anybody with chronic or acute difficulty in swallowing, which is dysphagia, also makes for a problem clearing fluids and solids from around the glottis. Somebody with postnasal drip, especially if they're leaning back in the chair, makes them very susceptible to the drainage affecting and causing laryngospasm. Any smoker, which includes anybody that vapes or uses marijuana, causes that smoke irritation to the glottis and the musculature and the tissues surrounding the vocal cords and the glottis, and that can lead to laryngospasm. When we apply sedation to a patient, especially it can be a moderate oral sedation or an IV sedation or a deep sedation in a general anesthesia, it really affects and makes their vocal cords, their glottic area, very susceptible for them not being able to cough and clear it themselves. And it's something that we would have to treat. But again, it makes them more susceptible to that spasm, and we really have to prevent that from happening. And then if a patient falls asleep, if we've given them too much sedation, or they might be very tired, or we might have a high concentration of nitrous oxide, the patient's going to really have trouble clearing that laryngospasm. Let's talk now about the treatments for laryngospasm. So when this occurs, again, it's a big surprise to all of us, and it's something that we have to get on very quickly and recognize it. As I said earlier, the best thing that can occur is for the patient to clear their laryngospasm by themselves. I would gently suction the area back there. If there's blood, saliva, water, or anything in the back of the throat, I don't want to go too stimulating or deep. If the patient can clear it, then I probably would leave it alone. But if they're under sedation, I would apply a Yankauer suction. You can use your slow speed suction and get it way down the back of the throat. We're going to have a picture of that in an upcoming part of your lecture. And then you would quickly, if it does not break, apply Larson's maneuver. This is a new treatment for laryngospasm. Other methods that you can use, and what we were taught early on, is to hold positive pressure with a bag valve mask, also called an ambu bag. You would increase the flow to high for the bag and the mask, get a good mask, and just apply positive pressure. You don't breathe the patient, but you apply positive pressure, and we're going to see pictures of that. And it's good to have a trained set of extra hands to help you, again, with these patients that are laryngospasmic. The other methods that we can use that are going to be a lot more invasive are to give IV lidocaine, 100 milligrams, in a rapid push to release and relax the laryngospasm. We could give 5 to 10 milligrams of succinylcholine. We're going to talk about that just a little bit later. Or now, because of a new reversal agent for rocuronium, you could give 5 to 10 milligrams to break the laryngospasm. But one of the best things to do is to use Larson's maneuver and positive pressure to break that spasm. Larson's maneuver works very, very well for the patient. Let's look at these methods more in detail. Let's talk about this new method called Larson's maneuver. It's an excellent method to be able to break laryngospasm very quickly. I would not use suction in this point. If the patient again is coughing and trying to break the laryngospasm by themselves, let them do it. So this is going to be for a patient that is unable to break their laryngospasm. So we're going to push in just behind the angle of their mandible, inward and hard bilaterally. It's very stimulating. After you see these pictures, apply it to yourself. You can feel how stimulating it is, and it will rapidly, usually break the laryngospasm. So it's again stimulating and painful to the patient when it's done properly. So we're going to take our fingers and put them behind the angle of the mandible, just below the ear, and we're going to push inward toward the midline. Here's another view from head on to the face, and here's a right side view. We're going to push really hard. So take a moment and push inward on your jaw very hard, and it'll push your jaw forward, and you can feel how painful that is. The second method is the bag valve mask. This is also called the ambu bag. So we're going to bring the ambu bag up. Hopefully it's going to be already assembled, and you're going to crank your oxygen up to full oxygen flow from the tank. Then you're going to apply proper mask fit using the C and then the E. So the C is holding the mask up and flush against the face, and the E are the 3 fingers on the jaw. And you're going to pull up and just apply pressure with the ambu bag. You're just going to hold pressure there. So we're applying positive pressure with a good mask fit. This is a Yankauer suction. If there's the chance of any secretions, any blood, water, saliva down there, you want to suction down to the depth of their throat, down to the base of the tongue, and really get everything up. We don't want to force that against the glottis. And here is a picture of suctioning deep down behind the base of the tongue and really suctioning the fluids out. One of the then very invasive maneuvers or things that we can do is to give IV medications if we're doing intravenous sedation on the patient. One would be to use intravenous lidocaine, succinylcholine, and rocuronium with sugammadex, and we'll talk about those in just a bit. Let's talk about some more invasive and more aggressive treatments for laryngospasm. We're going to talk about the use of lidocaine, succinylcholine, and rocuronium and its reversal, sugammadex. In order to break the spasm, after you've used one or two of the other methods, you can use these medications. It's found that 100 milligrams of intravenous lidocaine, this is preservative-free, it's multiple dose, it's not lidocaine from a carpule. So make sure you have this in your emergency drug kit or in your drug kit. The lidocaine, again, is quickly redistributed, so its effects are short, but it can, I can't say it always does, but it can break the spasm. Here I am pushing a syringe with 2% lidocaine. I would use 5 milliliters of 2% lidocaine. That's 100 milligrams. 2% is 20 milligrams per milliliter. Another method that's always been taught is that you can draw up succinylcholine, and some dental boards require that you do this into a syringe and give it, it's 20 milligrams per milliliter. You would give 5 or 10 milligrams into the IV to paralyze the vocal cords and to paralyze the structures around the area. Anytime you use succinylcholine, though, there are some real bad side effects from it, and we'll talk about those in just a little bit. One of the newer methods that's been recommended by at least the American Association of Nurse Anesthesiologists and the American Society of Anesthesiologists is the use of Zemuron. It's also known as rocuronium, and it's a non-depolarizing muscle relaxant, where succinylcholine is a depolarizing muscle relaxant. And they've discovered a sugar molecule that was introduced a few years ago that's called Bridion or Sugamidex, that is a sugar structure that surrounds the rocuronium molecule intravenously and neutralizes it so it won't paralyze any longer. So this is a new quick treatment. So succinylcholine and rocuronium are both skeletal muscle paralytics. And if you're going to use those, and like I said, some dental boards may require that you do that, you're going to have to use and know how to use a peripheral nerve stimulator and have one of those in your kit if the board requires it, and anytime you use one of these paralytics, so that you can document that the patient has regained the use of their skeletal muscles, and you can document that in their chart. So I'm showing you the basic parts of the peripheral nerve stimulator. You can see that there's an off-on switch. It's actually a dial, and you can dial up the amount of electricity that you're giving the patient for the shock. I usually turn it on full blast. And you can see that this looks a lot like an old transistor radio. Then we'll be using the TOF button. This stands for train of 4. This provides twitches that are stimulating the skeletal muscles of the face so that you can see 4 equal twitches when you press that TOF button. And that's what you're looking for to show that you've regained relief of the paralysis so that there's no longer any paralysis in the patient. So here you see that we're applying that to the face, and you would watch the patient's face for that. So again, you want to see 4 equal in intensity, 4 equal height twitches, every one of them the same, that are sent very quickly to the patient to test the strength of the muscle. If worse came to worse and the laryngospasm did not break, you have your emergency cricothyrotomy kit that goes into that cricothyroid membrane so that the patient doesn't desaturate, bradycardia down, and potentially die. And it happens very quickly. That's why you need to get on this as quickly as you can. Let's talk some more words about succinylcholine. I use the drug quite a bit in the operating room, but it has got some really strong problems with it, and I want you to be aware of this drug. And again, if your dental board requires it, then you need to have it in your refrigerator and make sure that it hasn't expired or anything. There was word years ago that if they were trying to get succinylcholine approved now through the FDA, it probably would not be approved. But again, we use it quite a bit in anesthesia because it's so quick on and it's so quick off. There's no reversal for it. We metabolize it with an enzyme in our bloodstream to break it up into parts so it's not paralyzing anymore. But the big thing about succinylcholine is that it can trigger malignant hyperthermia, and I want to basically show you what that is. It's a severe, life-threatening emergency, and standards say that if you're going to use it, that you need to have dantrolene stocked in your office. It's the reversal, and it's the main treatment for malignant hyperthermia, and we just don't want this to be happening. As I said, it's life-threatening. This would be a call 911 emergency. Again, I don't think I'd use succinylcholine, but I'm telling you that because dental boards may require that, and you may need to go before your dental board in order to tell them that there's different ways to treat laryngospasm. So again, it's really rarely used in the office. Some states require it. You're going to have to check your state's rules to see what they say. I live in Missouri, and I can tell you that it is required there if we're giving either deep sedation or general anesthesia. So I carry it around as if I was doing anesthesia between offices. If I was going around to different offices, I would carry it in a cooler with me. So you only need about 1/4 to 1/2 milliliter of the drug to break the laryngospasm. This is a molecule of acetylcholine. Our parasympathetic nervous system releases acetylcholine to each of its receptors. The main parasympathetic nerve is the vagus nerve that wanders through the body. Acetylcholine's effect on the heart slows the heart down. The effect of the parasympathetic nervous system is to kind of aid digestion, salivation, help you relax. It really slows the body down. But what we did with acetylcholine, the chemists, they created succinylcholine. So if you look at the molecules, you can see it's two acetylcholine molecules back to back. And they cause skeletal muscle contraction. The natural enzyme that neutralizes acetylcholine is acetylcholinesterase. The enzyme that is going to neutralize the succinylcholine molecule is pseudocholinesterase. And it takes longer for that to happen. So with malignant hyperthermia, the muscle's sarcoplasmic reticulum releases an immense amount of calcium when we stimulate it with succinylcholine. So you'll see that calcium is just flooding the area, and it will cause a stiff contracture, and hypermetabolic means are going on that generate a lot of carbon dioxide. That is the first thing we're going to see with malignant hyperthermia. And I know it's got the word hypothermia in it, but it also causes an increase in temperature, but that is not the immediate thing that happens. It's an immense amount of carbon dioxide. The muscle is in a hypermetabolic state, and the only way to quench that is with either ryanodine or dantrolene. Ryanodine is a lot more expensive. It's easily mixed up. Dantrolene, you have to have 60 milliliter bottles of sterile water, and it's real hard to dilute it. And it has to be given in a dose, and you would call the malignant hyperthermia on-call line to help you through this crisis. So again, you're going to see a dramatic increase in end-tidal carbon dioxide. The temperature is going to increase to well over 108 degrees Fahrenheit, which is 45.5 degrees Celsius. Very hypermetabolic. So let's see and kind of summarize all the laryngospasm treatment steps. So if a person develops laryngospasm, we recognize it quickly and let them clear it. That is the best way for them to break their own laryngospasm. And again, if the patient is highly sedated or asleep, it's going to be really hard for them to generate a good high pressure cough to break the spasm. It's just a naturally occurring thing that happens with our bodies to open our airways. We're going to use the tonsil suction, the Yankauer, or our slow speed suction, both of those until you get the Yankauer hooked up to your high speed suction to suction way down deep in the throat. Larson's maneuver was where we push inward and hard behind the ascending ramus to break the spasm, and we're going to really stimulate the patient. I hope you had a chance to feel it. It is not a good feeling to feel the pressure behind the angle of your mandible when you push in really hard. And there's pictures of us applying the Larson's maneuver to a patient. And you saw the movies earlier, hopefully also. The other thing was the bag valve mask, where we're going to have it open full blast on the amount of oxygen output to really fill up the reservoir bag, which is by the dental assistant's right hand here. It's that clear plastic bag. That's going to fill up, and that's going to be the reservoir for the oxygen that's going to be in the bag itself. We're going to have a good fitting mask. We're going to apply it to the face with the C and the E and pull the face up into the mask, hold pressure with either your right or left hand, depending on if you're right or left-handed. You just hold pressure to break it. The reason I have you suction it beforehand is so that you don't force blood, or if there's any debris, solid debris, or mucus, or saliva, whatever's down in the back of the throat. We saw the lidocaine, and you know the dose for that now. That's something that your dental board may require. I can tell you that we, as anesthetists, found that this works really well. And again, for us also, this is a really rare thing. We want the patient to break it, and we want to suction their mouth, even if they're sedated. So succinylcholine is really, really rarely used. I have emphasized that. And if you do use any kind of muscle relaxant, be it succinylcholine or rocuronium, you have to know the way to be able to use a peripheral nerve stimulator. There are 2 movies here that show you with a patient what it will look like when they are back from their paralysis. So I'm on the left side of the patient's face, and you will see their muscle twitch in 4 equal big twitches. I turn the peripheral monitor nerve stimulator on full blast. So rocuronium, not being a depolarizing, but being a non-depolarizing muscle relaxant, will not trigger malignant hyperthermia. The reason that succinylcholine is depolarizing is because it mimics and it looks just like the acetylcholine molecule. It's 2 acetylcholine molecules, again, back to back. And the nice thing is with rocuronium now that it's rapidly reversed with a dose of Sugamidex. The dose for Sugamidex is 2 milligrams per kilogram, and there's 200 milligrams in one of these bottles. It takes a while, though, for rocuronium to circulate, especially in low doses, to break the laryngospasm. Again, I'm not a fan of any of the 3 ways to break the laryngospasm, be it lidocaine, be it succinylcholine, or be it rocuronium. So we can see, as we talked about earlier, that Sugamidex, which is an unbelievable molecule, it was really interesting how they discovered this. It encapsulates and neutralizes the rocuronium molecule. And you can see what the Sugamidex molecule looks like in the top part of the picture, along with the Bridion bottle, and how the sugar surrounds and neutralizes the rocuronium molecule. Another definitive way that we talked about, just in review, is an emergency cricothyrotomy. Make sure that you know how to use it and where to use it. It's a good idea to palpate on your dental assistant, on your wife, on yourself, where your cricothyroid membrane is, between your Adam's apple, which again was the thyroid cartilage, and the cricoid cartilage. Let's talk about the prevention of laryngospasm. Just to put everything in perspective, laryngospasm should be a rare and almost never happening event. You're controlling the blood and any saliva and any debris that could fall down into the back of the throat and trigger laryngospasm. One of the nice things if you're doing IV sedation is to use glycopyrrolate, which is also called Robenol, in a real light dose. It's like 0.02 milligrams per kilogram, and you have to give it kind of early because it's such a low dose, and it will make the mouth bone dry as far as any saliva output. It's an anticholinergic, so it will work against the parasympathetic side and the acetylcholine molecule. So these prevention measures are to position the head and neck into the sniffing position. I sit the patient's head up slightly so that the body is not parallel to the floor. I want the head in more of an upright position, especially while I'm doing sedation or anesthesia. Have your slow and your high-speed suctions ready. If you're using the slow speed suction, the saliva evacuator, make sure the tip is on firmly, because if the tip falls off, that could be a real problem if it falls into the back of the throat. You would have to use your laryngoscope and your McGill forceps to pluck that piece of broken off slow speed or the saliva evacuator suction. And we also want to have a Yankauer suction. There are available for you to buy Yankauer suctions that are able to be sterilized in your autoclave, and they have a tip on the end to be able to fit into your high-speed suction, and you should have that definitely in your drug kit. So make sure that your dental assistant is suctioning every drop all the time. Don't have anything going into the back of the throat. You're using either a rubber dam, or you could use a very lightly moistened 4x4 in the back of the throat to catch any debris or anything that could potentially fall down the back of the throat. Isolite is also a wonderful suction to be able to use. I used to use, when I was doing anesthesia in dental offices, very lightly moistened 4x4 so that the little hairs wouldn't stick to the tongue. And you just, on a pretty deeply sedated patient, you're able to push that in back of the tongue, but something so that you could reach it with a college forceps, let's say, to pluck it out very quickly, or to change it if you needed to change it. Have your bag valve mask and your oxygen with a full tank ready to go and somewhere nearby so that you don't have to scamper to be able to go get it. And that glycopyrrolate that we talked about, it's a really low dose. I used, as I said, 0.02, but you can use 0.05 to 0.1 milligrams IV. And it just works really well, but it does take time to really make the patient's mouth bone dry. So there is the sniffing position again, and you position towels or pillows underneath their shoulders to get them into that sniffing like we would for a piece of pie position. So there's a pillow that goes in back of their head, and towels or blankets to get them into that sniffing position. In the operating room, I do with an obese patient, to get them into the sniffing position, is to build up a bunch of towels and blankets loaded in that order to be able to get them into that sniffing position. That's the ideal position for breathing, and an ideal position for you to be able to work on the patient without getting into trouble, especially problems with laryngospasm. I've really emphasized the sniffing position. I think you've got that one down. There's that slow speed or saliva ejector, and just suction in their mouth, and the reusable Yankauer suction. Just keep every drop from ever coming into their mouth. It's got to be all the time, every drop of blood, every bit of water from your high-speed handpiece, just anything. And there's an isolate. Very, very good for using suction and just keeping the area that we're working on in the mouth isolated from the throat and from any debris going down the back of the throat causing the laryngospasm. There's a 4x4 gauze. I used to just take it and put my finger in the middle of the 4x4. Notice it's not a 2x2, but a 4x4. So you'll have to buy a packet of those. Lightly moisten it and just push it in. It looked kind of like, if you will, a parachute going in backwards into the back of the throat. It keeps the tongue away from the back of the throat as far as for your airway, and it also keeps debris from falling down the back of the throat. There's your glycopyrrolate, and there's a picture of the parasympathetic nervous system. Remember that the vagus nerve is the main parasympathetic nerve that wanders. Vagus means to wander. It wanders to a lot of organs in the body. So in conclusion, you're going to be sedating patients along a depth of sedation. Most of you are going to be using moderate sedation, and I want to point out what moderate sedation is, because you will if the patient goes deeper, have to rescue them from one of the deeper depths of sedation, and you may not have a permit for that, but you've got to be able to rescue from that. So with moderate sedation, also called conscious sedation, the patient has a minimally depressed level of consciousness. They are able to talk with you. If you want them to tilt their head up in the air, they'll be able to do that. If you want them to turn their head to the left or to the right, if you want to ask them questions, they should be able to respond to you. When they get into deeper levels of sedation, we're going to start to lose these protective abilities. So in moderate sedation, the patient continuously maintains their airway and they're breathing spontaneously, so they're on their own. And they can respond to touch, light touch, and verbal commands. It's really important that they remain in this level so that you're compliant with your permit. And this state can be produced by pharmacological means, drugs like triazolam, or if you're using IV, drugs like Versed that can lightly sedate the patient and put them into this moderate sedation level. And they maintain their normal heart rate and blood pressure, which is their cardiovascular function. So keep that patient in that depth. If you have to touch up the sedation a little bit, don't overdose them. Keep them in that depth. I want to thank you for taking the course.